Hi, so good day everyone. Welcome to a part 2 series of our discussion that's all about the anatomy and the physiology of the respiratory system. So, disclaimer again, I'm a third year respiratory student, and right now I'm still figuring things out, and this is a video that's all about um applying my skills with the use of Feynman technique. Okay, so and last time I found myself stuck with um the anatomy. Okay, and have saw I saw that I'm kind of confused with this, yung parts ng bones and yung cartilage, gato ganyan. And I decided to continue this since I really wanted to do videos and find myself 10 years from now probably have done this video and I will reflect on this. And ayan. So enough of that. Let's start here. The anterior 1/3 is composed of nasal bone, which is what we call as the bridge. That's what we've learned before. And then we have the lower 2/3, which is all about the lateral nasal cartilage, the greater alar cartilage, the septal cartilage, the fibrous fatty tissues, and the lesser alar cartilage. And yung section na nanitira, or the section that's left out here, is our frontal process of maxilla. I'm kind of confused with this because you will be definitely confused because the frontal process of maxilla is right where? Here. We have here what we call the palatine process of maxilla. So if you kinda look at it, where could that frontal process of maxilla be if the nasal bones are just right upon that, and right up here we can only see that the areas next to the nasal bones are the cribriform plate of ethmoid bone and the perpendicular plate of ethmoid bone. So it's just all about ethmoid bone there, and sphenoid, but it's too far. And my last resort here was the palatine process of maxilla, since I have a confusion with this because, as you can see, the hard palate is what we call as the palatine process of maxilla. Then how about this? Why is it that the frontal process of maxilla sits right where probably the cribriform bone or plate is, or probably even the lateral there can see it? Vomer, yeah. Why is it that in that part where the frontal process of maxilla is, why is it that it's not ethmoid, and why is it that it's not vomer for such, right? So I can't give you any answer for that as of now, since I haven't done my research, but just decided to continue with this. And it's a good reflection on what we should focus on and what are the things that we have gaps on, right? So I forgot where I was left with, but Yeah, there's our structure of the nose. So the air that enters the nasal cavity through the two openings are being formed by our septal cartilage, which is this. Okay, the part where this dividing the left and right nostrils, and here nostrils. So initially the air passes through a slightly dilated area called the vestibule, which is this. The area where air enters. Vestibule, just a fancy word, which contains hair follicles called vibrissae, which is our nose hairs that filters again um, dust, pollen, not pollen, but probably, but just foreign objects to be prevented from going down into our lower airways. And yeah, here it is. The vibrissae is a filter in the first line of defense of the tracheobronchial tree, okay? And then, so it is lined by stratified squamous or squamous epithelium. It is non-ciliated that lines entire one-third of the nasal cavity, okay? So the area where, for example, the vestibule is, and then a few probably areas away, is that it is lined with a tissue called stratified squamous epithelium non-ciliated. What this means is that stratified means marami or many, and then squamous is like parang naiipit, nagmimixed, or what's the word for that? Combined or like flattened. And then epithelium is the lining. It's non-ciliated, therefore it doesn't have cilia that lines the one-third of the nasal cavity. Its function is to, of course, prevent it from abrasion. Okay, and then here we have the posterior two-thirds of the nasal cavity, in which let's just say after you go through the anterior one-third, which is lined with stratified squamous epithelium, you will be left with pseudostratified ciliated columnar epithelium, which is aligned two-thirds again, because the first area is studded with that type of tissue, the stratified squamous epithelium. When we go ahead, we will see the tissues, the pseudostratified ciliated columnar epithelium. Okay, so pseudostratified is fake, pseudo is fake, and then stratified is a lot of cells, tissues, and then ciliated, it has a cilia which moves and propels debris, organisms, you say it, you name it. Then columnar, because it's kind of large and thick. Epithelium, it's like shaped in columns. Okay, so it is lined with pseudostratified, a somewhat like a lot of striations. However, columnar lang talaga siya, desiccated. And so the cilia propels the mucus towards the nasopharynx, and it is where we can probably dispose it, right? And there's a theory, I don't know if that's kind of true, or I don't know where did I learn that, or if it's legit, but if it's in the nasopharynx, yeah, I mean, don't consider that. I just kind of realized that when it's in the nasopharynx, you can expel it. You can just let it stay there, but it's going to really expel. Or yeah, okay. So what I'm thinking is, you can swallow it, but it's already in the nose. How can you swallow that, right? So, I don't know. Then here we have the nasal flaring or the alar collapse. Okay, so um, let's just skip the readings here. If you want to read, you can pause and read. But to give you a summary, nasal flaring is a sign of respiratory distress, as you can see. It's because there's probably an increased need for oxygen. Therefore, it the result would be the the nasal the structures of the nose. Remember the alars. The nose will flare or it will seem to look like this, the letter B figure, so that it can compensate or get in more oxygen. So it happens because of an increased airway resistance. Okay, then it's probably because that the lungs are stiffer than normal. And with that said, the help that we can get from using that muscles, or I mean cartilage, or that movement, is that we can generate a greater than normal negative pressure during each inspiration to pull air into the airways more rapidly. So that kind of action has a reason why it's happening. It's because we are compensating for airway. Okay, we need more ventilation. Okay, so that's why there each inspiration will have to pull more air rapidly. That happens because we know that there are problems such as increased airway resistance. For example, if our airways are blocked, obstructive and unobstructive disorder, right? So if that happens, the air can come in, but the air can't come out. So the alveoli will become hyperinflated. It's because of the increased airway resistance. Up until the alveoli, yes, secretions can be present, and that signifies an increased airway resistance. If we flare up the nose, our body's trying to compensate to bring in more ventilation and counterpart the effect of the resistance. Okay? Pero that's not enough. And then second is if the lungs are stiffer than normal, our body's going to try to compensate itself, because if the lungs are stiff, you can literally expand it, right? Then our body's way of helping it is to flare our nose to increase or bring in oxygen if the lungs can't expand because it's stiff, right? So that's just basically how I understand it. And here we have alar collapse, which is the absolute um, difference, absolute what was the word? The absolute kabaliktaran, or the absolute opposite of nasal flaring, because alar collapse is basically the way our nostrils collapse, just like in figure D. So it is an important sign of nasal obstruction. So how can we say so? Hmm. What is the pathophysiology or reason behind why it why does the alar part collapse? I haven't thought of that. We know that when that happens, it will be difficult for us to breathe in if the alar is collapsing. Therefore, it's totally common to find them as an obligated mouth breather, yeah, and can really cause snoring or sleep apnea if it's obstructed, really. Okay, so I just figured it out. Alar collapse. So it is an important sign of obstruction. Why? It's because the air can't come in properly. That's why it's obstructed. Okay, let me rephrase that. Alar collapse happens because of the total collapse of the nostrils. When that happens, nasal obstruction happens. Can you visualize it now? Visualize a nose and nostrils, and this, the figure D, being collapsed. If you inhale air in, the air coming inside us are decreased. It's because of the obstruction. Get it now? Our problem here is the obstruction. The nasal nostrils being an obstruction. See? This is an important sign of nasal obstruction. Then, what's next? So, again, our problems here is the nasal flaring and alar collapse. Remember that A and is our normal. The C is kinda problem too because it's an alar collapse. However, whenever you exhale, so it's kind of looking like it's returning or recoiling to its normal position, and the D part is like really obstructed whenever you inhale. Okay, then here we have an explanation of why the nose is a route for administering topical agents such as nasal spray. Okay, so I'll make this short. Okay, it has in my understanding, the nose is a great way to give medicine or remedies or medications. Okay, because it is studded with a lot of blood vessels that can carry the medicine and serve its action. So, such as nasal sprays, when you put in the medications, our blood vessels are present inside our nose because I suppose that the blood vessels are situated near the parts of our nose, and if you put it there, will produce a local effect. It says here that it can just give a little or to no systemic absorption. Therefore, it does not overcomplicate by producing its effects on the other organs. Okay, so its effects are only for the nose. Okay, so as an example, mucinephrin or phenylephrine, a sympathomimetic alpha-stimulating vasoconstriction drug which treats nasal congestion, is um, given to patients to prevent nasal congestion. How? Sympathomimetic. It it um it it constricts vessels. It's alpha stimulating. I'm not pretty sure with alpha stimulating, but alpha stimulating is like does an effect on the heart, but it's not systemic. Okay, maybe you can just search it in vasoconstriction. Alpha stimulating. Okay, so in other words, um, the nose is a great route for giving in medications, such as when you have problems with the congestions, and the effects are fast, and it is beneficial because it produces little to no systemic absorption. And however, few people will be open with this and try to abuse it. And it says that if you try it very multiple times and in many many times, the effects would be not so effective as before. Okay, so here we have our lining. Okay, so last time we have described that the anterior 1/3 of the nose is covered with stratified squamous epithelium. I've memorized that. And the 2/3 are lined with pseudostratified ciliated columnar epithelium. And then when we go down, it's going to be lined again with stratified squamous epithelium, as you can see. I have to say that this type of figure helped me out because I can't just get an information just by words, but also from looking at it. And this has helped me a lot. And then we have pseudostratified ciliated columnar epithelium again on the tracheobronchial, in the trachea and the bronchi, tracheobronchial tree, in other words. Then we have our small bronchi, bronchioles, and then here's our alveoli, which is the pink one. So if it's color green, denotes simple cuboidal epithelium, which is a lot more smaller in compared to the columnar epithelium. And then we have the smallest of the smallest, which is the presence of the simple squamous epithelium, which helps to facilitate easier and better diffusion of oxygen and so as carbon dioxide. Okay, so here's that. Okay, so the sense of smell, olfactory regions are near the superior and middle turbinates. When the nasal mucosa or nerve endings are irritated with particles such as pollen, dust, sneeze reflex happen. Okay, the two nasal passages between the nares and the nasopharynx are also called the choanate. excuse my pronunciation if it's not right. But yeah, so the section between nares and the nasopharynx are called coni. And then what part of the respiratory system is responsible for humidification and warming of inspired air? What could your answer be? It's the nose, but particularly it's within our turbinates. Okay, so here, our sense of smell, it is with the presence of olfactory region, our cranial nerve 1, it is situated near our superior to middle turbinates. With the presence of this olfactory region, we can smell. Here we also have nosebleeds or epistaxis, which is very common. And did you know that there are two types? The anterior nosebleeds and the posterior nosebleeds. Anterior nosebleeds are common because cases can be from a 90% accidents and compared to posterior nosebleeds, which is probably the remaining 10%. They are stopped by simply pinching the nostrils and close or pack them with cotton. That's our first aid. So when anterior nosebleeds happen, it's probably because of trauma. Okay, so it's probably because of the weather. It's probably because of the physical trauma, such as nose picking and blowing it too hard, for example. And what else? Can probably be from the dry air and harsh weather, and that's all I can think of. Anterior nosebleed happens, but these things are way more easier to have because posterior nosebleeds are the absolute problem. Because posterior nosebleeds are less common. If posterior nosebleeds happen, it is dangerous because the bleeding usually originates from an artery located in the back of our nasal cavity. So it's an artery, okay, which supplies blood, oxygenated blood. So if that thing or that artery is what do you call that, affected, therefore supplies of oxygen could be affected. So blood usually flows down the back of the pharynx even when the person is sitting or standing. So usually it's with elderly and it requires hospitalization for management. Okay, so yeah, posterior nosebleeds can happen from serious nose trauma, the extreme physical accidents, and nasal-mucosal infection, high blood pressure, nasal tumors, atherosclerosis, and drug abuse and leukemia. Then we have nasal congestion that's influenced with taste, rhinitis. I just realized I was done with this from the first one. And yeah, we have these types of sinuses, the maxillary, frontal, ethmoid, and sphenoid. Here, I just realized I'm done with this. Oh my gosh. Okay, So sinusitis is the inflammation at our sinuses. We have sinuses here. Four sinuses actually, which are these: maxillary, frontal, ethmoid, and sphenoid. We have also nasal polyps, which are non-cancerous, but probably a main reason for why we can have um, is it or we can have nasal congestion, sinusitis, and trouble of breathing. Okay, so here we have the anatomy of our oral cavity. We have the hard palate, which is the frontal process of maxilla, and soft palate, and then if it extends backwards, it's with the presence of uvula now. The palatoglossal arch, the palatine tonsils, which are paired, and it's for immunological defense. Palatopharyngeal arch, which is way back than palatoglossal, and oropharynx. So the tongue is an important tool for us to say k, t, t, okay? And it's used for repositioning the food we eat, which creates what we call bolus, okay? Then it has two types of muscle: the intrinsic muscle and the extrinsic muscle. So if intrinsic muscles are located in the tongue and are not attached to bone, extrinsic muscle on the other hand is attached to the bone. Okay, but so here the tongue, it is secured to the roof of the mouth by fold of mucosa called lingual frenulum. The lingual frenulum is below our tongue, which keeps it on its position. So see, it permits the posterior movements of the lungs. We also have papillae at our tongues, which are peg-like projections that gives the tongue surface a slightly abrasive feel. There we can taste the qualities of sweetness, sour, salty, bitter, and umami. Okay, so the soft palate closes off the opening, so it's moving upwards between the nasal and the oral pharynx during swallowing. When we swallow, closes, moves upwards, remember, sucking and blowing. So the main muscle responsible for that is our levator belly palatinum muscle. It elevates the soft palate. Then we have pharyngeal muscles, which draws the soft palate forward and downward back to its position. So the oral cavity again is lined with non-ciliated stratified squamous epithelium. Okay, and then we have here the palatine arches, and then the palatoglossal arch, palatopharyngeal. So we also have the palatine tonsils, which are important or fossal, which are located at the sides of our oral cavity. Okay, so adenoids are located at our posterior nasopharynx, remember that, and if it's palatine tonsil, it's in our oral cavity. So next is our pharynx, We have nasopharynx, oropharynx, and laryngopharynx. Nasopharynx are the sections between pharynx and the nose. Okay, so it is a location where our pharyngeal tonsil or the adenoid is placed. And then this also where our pharyngotympanic or auditory tubes are placed. This responsible for the equalization of pressure within the outside pressure and the inside pressure. So if you have a problem with nasal congestion, can have an effect with spreading it into our ear, or because remember that it's located in our nasopharynx, and it's kinda having a tube that's kinda connected to our ear, and if our nose is infected with infectious agents, it can spread out into the distant areas such as in our nose. So a common diseases that's seen within patients is within children are the what we call otitis media, or it's the ear infection, what we call. It's an infection because it can be caused by moraxella. I forgot. Here, Moraxella catarrhalis, Streptococcus pneumoniae, and Haemophilus influenzae. So, when that happens, it's going to be inflamed, and it's going to be open. I'm not pretty sure. So originally in young children, pharyngotympanic tubes are shorter and run more horizontally. So that's the reason why they are more prone or susceptible to this type of middle ear infection. Okay, but however, as the child grows older, the shape becomes more oval, and it shifts from that type of very susceptible to less susceptible, because the auditory tubes shift downwards or become more vertical in the upright position. And yeah, so symptoms can be low grade fever, lethargy, and irritability, which are sometimes not easily recognized by parents. So this disease can be a cause of hearing loss and fluid buildup. That's what I'm saying earlier. That dampens our tympanic membrane or eardrum. So when this happens, large amount of fluid or pus accumulates in the middle ear, and a tiny tube inserted in the eardrum permits. Okay, so myringotomy is a procedure done to help patients with otitis media, because it is a procedure where a tiny tube is inserted into the eardrums to drain fluids or pus into the external ear. Then here's our otitis media, the eustachian tube. We also have the vallecula epiglottica, which is an important site for intubation. So later we will see an illustration of vallecula epiglottica. But here we have laryngopharynx, which are also called hypopharynx. So it lies between the base of the tongue and the entrance of esophagus. So this part is kind of difficult for me before, and I suppose that now I kind of get the hang of it, but still needs to find more information about this. Okay, so remember that when we say laryngopharynx, it starts with the base of the tongue. Okay, it's because after nasopharynx and oropharynx, we have laryngopharynx. It starts at the base of the tongue and ends within the sections of the trachea and the esophagus. But yeah, it's within that bifurcation that it ends. So it is lined with non-slated stratified squamous epithelium. And then still, the epiglottis and okay. So to give you a summary of the laryngopharynx, we have overall 3 paired cartilage and a 3 single cartilage. The 3 single cartilage are the epiglottis, the thyroid, and the cricoid membrane. Okay, and then we also have the paired cartilage, which is arytenoid. Okay, arytenoid cartilage, corniculate, and what was that again? Corniculate, cuneiform. Okay, so we also have here the pharyngeal reflex, which is the gag or swallow. Here it is where it happens. It's with the sensory innervation of the 9th cranial nerve and motor innervation of the 10th cranial nerve. Okay, so here's our base of the tongue. This is where the hypopharynx starts, and up to the bifurcation here. So basically this is our hypopharynx. Okay, so the vallecula epiglottica, as you can see here, is a site or landmark for intubation, or for putting in your endotracheal tube, or yeah. So this is where like a small small space is present. That's why it's like a landmark. And we have here epiglottis, the true and false vocal cords, the epiglottic folds, the trachea or glottis, cuneiform cartilage, arytenoid cartilage, and corniculate and cricoid. Okay, so this is kind of hard, but I'm going to try my best to explain this. So the false vocal cords are located on the sides of the true vocal cords, because basically the true vocal cords are the vocal cords that produces sounds. Okay, remember that. It's true because it produces sounds. Okay, it produces sounds by vibrating, and there's the false vocal cords to support it. Around it, we have the epiglottis, the arytenoid, the corniculate, the cricoid, then inside that is our trachea, or what we call as the glottis. It's probably what we call as the rim of this if you proceed into this chapter. So here we have our endotracheal tube. So this is the ETT, or endotracheal tube. Okay. And we have the cuff tip that separates the lower airways from the upper airways. Okay. So I suppose the main purpose of this cuff is so that no air will escape, no air will um mm, a fixed variable will be given to the patient. So there are many types of endotracheal tube, the nasal ones and the oral ones, or it can be also tracheostomy tube. Okay, so when all of these are remembered to are delivered, the patient of course must receive a proper warming and humidification of inhaled air, okay, so that it can dehydrate their mucus layer, the tracheobronchial tree, okay, and then because if that happens, the mucus layer will become thick and airway management or secretions will be thicker and harder to expel. So, okay. The major anatomic landmarks of the laryngopharynx and larynx is, for example, the vallecula epiglottis, ganyan. You have to learn that, especially when inserting in the endotracheal tube. So, intubator should always be mindful of the fact that in children, the smallest upper airway system is the cricoid, and the smallest part of the airways for adults is the glottis. Okay. Hmm. Here we also have a situation where an endotracheal tube is misplaced, and instead of going to the trachea, it's inserted to the esophagus, which is not good because the stomach is inflated instead of the lungs, which needs the air. When that happens, as you can see, an X-ray was provided and this happens. See that the air is like color black, right? Remember that when it's black, it's air. And as you can see, the lungs are black because it has oxygen. As you can see where the letter B is, it's color black. So that's the patient's stomach being increased with air. So that's not good because can probably cause dangerous here. So you can see in certain patients esophagus rather than trachea, especially during emergency situation. That commonly happens because people are very important and it should be done fast, such as that. So as you can see, the anatomical landmarks are very hard. That's why when we insert ETT, we have anatomic landmarks such as vallecula epiglottica to insert it to, and not in other places such as at the back of that hypopharynx is the esophagus. Okay. We also have this, which are described earlier, and these I'm not well handed with the intrinsic muscles yet, but I'm good with this, the laryngeal cartilage. And here's what I've said earlier. We have these things. We also have vocal process and ligaments, okay? So when we say vocal process, these are the things that holds the true and false vocal cords. The vocal ligaments are like probably the supporting features to control the vocal process or cords. Then we have laryngitis here, which is the inflammation of the larynx. It's very dangerous because, as you can see here, can obstruct the airway. Laryngitis, inflammation of the airway. So here, oh my gosh, it's 1:57 in the morning. Treatment consists of aerosolized alpha-adrenergic drugs such as racemic epinephrine. Yes, we also have group syndrome, which is also known as inspiratory stridor. Can be caused by laryngotracheobronchitis or LTB and acute epiglottitis. These things are important, life-threatening emergency because the airways are being obstructed. There's no way air can go through this if it's narrow, right? Here we have a swollen epiglottis. Here we have a swollen glottis, okay? And we have laryngeal musculature, what I've said earlier. When you use the posterior cricoarytenoid, the muscles will abduct, and it allows air to pass. When lateral cricoarytenoid happens, the vocal cords will adduct and will cause closure, right? Adduct, and then when transverse arytenoid abduct, move apart. Adduct is to close. Transverse arytenoid muscles are for singing, speech. Thyroidenoid are for contracting or loosening the vocal ligaments for phonation, like these. Okay. You also have cricothyroid muscles. Then the ventilatory function of the larynx. So yeah, what time is it? I think I have to go to sleep. Okay, thank you. We will proceed to lower airways probably next time I have a time because I haven't done my assignments yet and I have a lot of backlogs with my school. I haven't done my airway management yet and my pulmonary disease management and pulmonary function test. And yeah, so I'll find a way to do a separate video again for this specific section.